Welcome. I'm Michelle McDonald, and I'm the Executive Director of Brain Injury Canada. I'm thrilled to have Dr. John Connolly with me today. Dr. Connolly is the Chief Science Officer and co-founder of VoxNeuro. Dr. Connolly earned his PhD from the Institute of Psychiatry, Psychology, and Neuroscience at King's College in London. He currently holds the Senator William McMaster Chair in Cognitive Neuroscience, is the founding director of the Advanced Research and Experimental and Applied Linguistics Center, and co-directs the Language, Memory, and Brain Lab, both at McMaster University. He is an author of over 330 articles, chapters, and presentations, most of which involve cognition and health and brain pathology. And I should mention that VoxNeuro is our platinum sponsor, and we thank them for their dedication and support and for all they do for those living with brain injury. So welcome, Dr. Connolly.
Thank you very much. Thank you. It's a pleasure to be here.
So let's just dive right in. We've got a lot to cover, and we want to hear so much from you. So a lot of your work over your career has been focused on those in coma or vegetative state. What do we know now about coma that we did not know 10 years ago?
That's a very good question. When I started looking at coma, for example, I spoke to a few colleagues and they said, well, if you ask 10 neurologists, you'll get 15 ideas. So it is a very complex condition. And also it is not one single condition. It looks the same. And this may be a recurring theme in the things that I say, that how things look is not necessarily what's going on. So to get to your question, in the last 10 years, I think we have some sense, and I only see this from my perspective. I should point that out. I do what I do. But I think one of the things that's most important is that, first of all, the work of a colleague in France, her name is Catherine Fisher, herself a neurologist. She really was the first person to use what are called event-related brain potentials, brain responses, to particular types of auditory stimuli. Just very simple stuff. But what happens with this, when you present auditory stimuli to a person in a coma or not, you will get brain responses. Now, if they're in a coma, they may show rudimentary brain responses and stop there. But what she demonstrated was that many did not. They showed a particular type of brain response that she used to demonstrate that the response could predict emergence from the coma. Not what the person would emerge like in terms of whether it's a vegetative state, a locked-in state, or just emerge. And as one of our patients did, say they were hungry. So you get a range of responses, but she would say, but they will emerge. And she demonstrated a 90% plus specificity to this response. So in other words, when people were judged, again, externally, behaviorally, to be non-awake, that 90%, over 90% of those patients did not show this brain response. Just for the record, it's called a mismatch negativity, but we don't have to get into that. But they did not show this response. Equally, those who did emerge, 90%, there was a predictive value that if you showed the response in coma, you would emerge. So it's a 90+%. The problem with, and she was very upfront about this, the problem with her work was that the sensitivity was a problem, that there were people emerging who never showed the response. And she just thought that undermined some of the work that she was doing in terms of how specific could she be about this is a very useful tool. And one of the ideas that we had quite some time ago, about 20 years ago, 21 years ago, and we had applied for funding to do this work, was to look at these patients, but for longer periods of time, so up to 24 hours. Because what I wondered at the time was, is it possible, because you see this in a lot of brain injuries, the person's, how much the person is tuned in whether it's a conversation or just to stimuli that are being presented, will wax and wane. And certainly there were anecdotes about coma patients that would indicate there were times during their coma when they had been aware of what was going on in the ward. They would say, was someone pregnant? I had this dream that someone was pregnant, and it turned out to be one of the nurses that was dealing with the patient quite a bit and would have conversations with her colleagues as she was dealing with him. And so I just had, it was all anecdote. And so what we did was we extended the testing of brain responses for longer than the one, like 25-minute, 35-minute test. We tested the coma patients for up to 24 hours. And we looked to see two things. Could we ever, within that 24-hour period, record this brain response? And if we did, was it a one-off occasion, or was it in fact waxing and waning? So I do think that one of the advances over the last 10 years is that we've now published several papers on this, that we find that many patients do show this response, and yes, it does wax and wane. So in other words, there will be times when they're showing it, times when they're not. And in fact, in a very small study, the first one we published, we just had a case study, 2 patients that we presented, and we demonstrated that we saw this response in them. It waxed and waned, so sometimes it was there, sometimes it was not. Both of them emerged. So the positive predictive value that Catherine Fisher spoke about in some of her patients, we certainly saw. The thing is, when we did the traditional analysis, because the way we did it was over the extended period of time, plus we used machine learning to look at the responses. We could see them with much greater resolution. It was like switching from just regular vision to a microscope. So we really could see the responses with much greater acuity, shall we say. And, but when we did the usual procedure that Catherine and we used prior to this, we found that they would have fallen into the category of emerging without ever having shown this brain response. So, and I think the other thing that's happened is there was for a period of time, and there still is, but it's really, the game is over. If you show this brain response, it means that you are in a conscious state. That is a very big deal. It doesn't mean you are necessarily consciously aware. It just means, because there are 2 different things there. And the best example I can use is for those of you who wear glasses, I do. I very often might be on the telephone or might be doing something and I put my glasses down. I then move to another room and I need my glasses. And I then have to figure out where I left them. When I put them down, I was not unconscious. I was conscious. I was just not consciously aware of putting them down as I spoke to someone on the telephone. That's what we're talking about here. And I think at the moment what we're doing, thanks to a federal government award, but we're doing work to see, is there any point at which patients that show this response that requires consciousness, doesn't mean their eyes open, it just means they are at some level aware of what's going on in the environment, but not aware in the sense of, I know where I put my glasses, that do they ever break into that other category where they really are attending to something? So we're running a variety of other tests during that 24-hour period. And we're still analyzing those. So I don't know if we get that, and that was something that Catherine Fisher and I would discuss not infrequently, that it's one thing to predict emergence. It would be quite another thing if we could predict what they're going to come out like, because the intent there would be the step-down clinic, the rehab people, they could get ready for what this patient was going to present. Furthermore, as I discussed with some of the people, we could actually begin some types of therapy, even while they were still technically in the ICU and technically in a coma. So it sounds very outlandish, but that's what we're doing. And that's really, in my world, that's the news of what in the last 10 years has been found.
That's incredible. It's fascinating. So for those families who are sitting with their loved one, is there anything that they, you know, not knowing if that person's not being monitored on your study, is there anything that, you know, that you can recommend for them that as they sit vigil beside their loved one?
I think, honestly, and this is a response I have to some television programs that I've seen, when they still have in dialogue, we can't tell if they can hear you. It's like, yes, we can. But it doesn't mean they might just hear it. They might not respond. But I will say, as one example, that, again, Catherine Fisher has, and we're doing the same thing, but she has already published on if you have someone's name spoken in the middle of other types of stimuli, they hear the name Michelle, or they hear the name John, and other names that are sex specific, so that we don't get that sort of confusion going on. If it is spoken by someone they don't know, or if it's even a very sophisticated artificial voice, they still show that brain response if they are in that state. However, when a familiar voice, for example, the person's partner, speaks their name, they show a different response. They show a response to that indicates a recognition of a familiar voice. There may be a range of low-level physiological reasons for that, but I think right now the more parsimonious result is that that there is a level of recognition going on, that they know who that voice belongs to, or they know about the voice, and that's a very significant result. The other thing is that in ICU it's one thing, and coma it's one thing, but in vegetative state, theoretically vegetative state, that's another thing where really the person should be tested, that somebody should use some technique to see if there is any response to external events, and that really should be mandated. There's a man in New York, Joseph Finns, who's talked about the day of considering not doing that as malpractice is not too far away. So he's quite vehement about it. And I think it really is the case. We could tell if there's something going on. A negative result doesn't mean nothing is going on. It just means, well, we have to test maybe more or do something more sophisticated. But I do think it is at that stage at this point.
Well, it's so important for all those families that are in that position of wondering what's happening with their loved one. That's crucial information.
Yeah, yeah.
So we're in the middle of a pandemic, hence why we're doing this online. So since the pandemic started, there have been some reports of neurological effects of COVID-19 on patients who have recovered from the illness. So can you talk a little bit more about that, and then also how VoxNeuro and their, the objective health assessments that you do, how do they fit into the treatment for those individuals? So it's a bit of a two-pronged question.
The thing that I noticed, there were two things that happened. The very first reports out of Wuhan, medical reports, were talking about up to 64% of the people they saw were exhibiting some signs of what they described as neurological consequences of the virus. They were at what you might describe as low-level neurological, but neurological nonetheless. Mm-hmm. It was then just days later, because reports were flying out from all over the place. It was an anecdote from New York. Then coincidentally, or not coincidentally, I was talking to a former student who works out in Los Angeles, a neurologist, but also got her PhD with me. And she was working in LA, and she said a lot of them have frank neurological symptoms. And she said it includes delirium. And that's where it becomes very interesting, because that comes with cognitive symptomatology as well. And as people started to get more and more information, it became clear that there were memory problems, there were language problems, there were executive function problems. So, and also, especially in Italy, they really jumped on this right away, so that they were opening neuro clinics in regards to these patients, these COVID-19 patients, that they were specifically targeting so that these people could go to particular locations, to clinics that were geared toward neurological and neurocognitive consequences. And that's where I first saw the term. Maybe someone else had used it already, but I saw the term used for the first time, neuroinvasive. And there's a very interesting group at Laval University in Quebec who has been looking at viruses like this for some time. And they had talked about some elements of neurological consequences to various already existing strains. And they were saying, they were even giving the mechanism of how it got into the brain through cranial nerves. And that is why, for example, another group talked about using the fact that someone loses their sense of smell or has very, very bad headaches. This other group was talking about this was the route by which the virus entered the brain. And I thought that was really very, very interesting, because they were talking about COVID-19 as being, they even suggested that because one of the targets, let's call it that, of the virus once it got into the brain was the medulla. And the medulla has a very strong representation in controlling respiration. Everybody was talking about respiratory problems at that stage. And this group suggested it could even be a secondary consequence of the virus, not a primary consequence. So I don't know that that's been confirmed, but it is certainly a neuroinvasive virus. And the issue of where we're involved is that in order to assess the cognition, I think one of the problems is that there comes a time when you just have to stop subjective opinion. When you look at someone, and vegetative state is a classic example where historically consensus diagnosis, which is the opinions of very skilled people looking at something that's very complicated and saying, I think this is vegetative state, and they agree. And that's the label the person gets. And even the people who developed one of the best tests around, the Coma recovery skill, the revised version, they found even when they administered it the first time around, they were wrong 36% of the time. So that is right in the ballpark, and that's a very good behavioral test. The point is, what you see in behavior maybe is not really what's going on, and that is just too common an occurrence. So I think VoxNeuro's role here is to, when you talk about executive function, that is a very overarching term. It involves a range of different cognitive functions. Which ones? And is it memory? Is it attention to detail? Is it concentration? And there's just a range of things. And I think that's really what our contribution would be to this. Because the other thing that the Chinese and the Italians who've had the longest exposure to this have been talking about is that these consequences do not go away. In many cases, this is now a person has, in a sense, recovered from the COVID-19 in some respects, but they have lasting neurological consequences. It's not everyone, but it's a percentage. And they have talked about the rehabilitation pandemic that's going to follow. Mm-hmm. So I think that's where we come into, we could help by saying, here's what's really going wrong, rather than just generalizations about executive function and attention. Get specific and get some measures that you can rely on day in, day out.
Wow. Oh, I'm sure there's going to be a lot more coming out as you know, further research happens with within COVID-19. So you talked a bit about, you know, subjective versus objective diagnosis, and diagnosis and prognosis are an ongoing challenge. And I know that that's one of the questions that families have when they're, you know, what's going to happen with my son, daughter, spouse, mother, father, whatever. But so how can common diagnostic errors of catastrophic brain injury be avoided?
I think it is, again, using biological measures. I think and I think one of the things you have to really look at then is a point of care system. A lot of these patients early in their condition really can't go elsewhere to be tested. And I think that's one of the real pluses of electroencephalography. And again, we really concentrate on one side of it, but I won't go into that unless it becomes essential. But we do look at particular types of it. And these are responses, this is not novel science. These are measures that have been around in some cases. One response that we look at was first published about in 1965. Another one, 1978. Another one, 1980. So these are very, very well established responses. We know what they're about. So, excuse me. I think the real issue is putting a behavioral test on an iPad is just putting it on an iPad. It doesn't make it objective. It just makes it easier to collect the data. And that's not trivial. I think one of the most, when I got my PhD, as you mentioned, it was in a medical federation. I was doing this within the Hospital Federation of England and London. And medical histories are absolutely critical. But then if you look at other disorders, other diseases, the first thing they then want is, can we get some CTs? Can we get some blood work? It's common practice. Well, it should be common practice that when you see a patient in a coma or in what you think might be a vegetative state, in other words, if there is some problem communicating with the person, it's either impossible or it's very, very laborious, and you don't trust, it's not that you don't trust the patient, you don't trust your ability to get reliable responses, then I think you should switch to a biological measure, because you can't fake those. Now, just for the record, I could, but if you were skilled, you'd know that I was doing it. And so effectively, you cannot fake these. These are robust, they're reliable. The reliability of these responses is very, very high. So I just think that the subjective opinion, as the developers of the CRSR, the Coma Recovery Scale Revised version, as they demonstrated themselves, it is problematic. They made error rates of up to 36%. So it is simply, you're looking at a patient and you make assumptions. There may be a lot going on. When we tested a man who was diagnosed as in a vegetative state by a world-class neurologist who has since passed away, unfortunately, Jane Gillette, she tested and she said, classic vegetative state. And then she also added, your turn. And this man, he went right up to showing speech comprehension responses. He was thoroughly there. And he received treatment and he made a wonderful recovery. And when we interviewed him, and we've kept in touch, it's been 10 years now since we first tested him, even longer possibly. But he remembers being tested, and he remembers what we said to him. And he remembers one time when we ran one test in particular faster than usual because we thought it was too laborious for him, and he couldn't do it. And he was upset. He said, I remember that, I panicked because I knew what you were trying to do, and I thought if I fail this test, they're going to make assumptions about my state. And unfortunately, it was a month later when we tested him again, so he had to go through that agony for a month because we tested him, and I said, I think last time we might have run this too quickly, so we would have run this more slowly. Responses came back. So he needed time to do things, but he was doing them. And so, like I say, he's made a very, very strong recovery. So it was not vegetative state. Jane, Dr. Gillette, was very excited about this. So at any rate, I think that's the difference between subjective views, even if they're skilled, versus objective evidence. Physicians would never send you for blood tests if they were just going to judge you by what they think is going on.
Right. Wow, that's an incredible story. Okay, so we've talked about catastrophic brain injury. Now talking about more mild traumatic brain injury, concussion, how can diagnosis of MTBI concussion be improved?
That's a good question. And I think diagnosis with cases like vegetative state as to whether it really is still risky. I would hate to, on the basis of our results, even say that someone is absolutely not there. There may be better ways that we haven't discovered yet. But concussion, I think the diagnosis is very problematic. What we do is we just provide objective assessment of the person's state. If the person, again, medical records and history taking, if the person has been in a hockey game, excuse me, and was checked into the boards from behind and was really injured and is now reporting feeling slow, the family says the same thing, and we test them and they show clear abnormalities in their brain responses, then we would say, well, certainly he has cognitive dysfunction. Given the history, it probably came from the hockey game and it probably was a concussion. I think the real issue is what we offer is that here's the condition, here are the different symptoms, because again, we see some people that can't concentrate, but their memory for things is pretty good, not around the injury, I just mean generally. Other people we see, they also have trouble with memory. So what we do is we say, here are the targets for problematic, here are the dysfunctions, and it's where a rehab person may want to focus some of their attention. But also what we can do with these same techniques in the VoxNeuro repertoire is we follow them. We can see as you begin to work with them, are they showing signs of improvement? And we have done that, and we can track these responses. And I think that's really where it would fit in with a concussion profile is diagnosis. I feel sometimes I'm almost trying to avoid the response because it is really complicated. These are very, very difficult things to make a strict diagnosis about. And especially if somebody has had concussions before and you didn't get a baseline from them. But we are baseline free. That is one of the features of it. We have a normative database. And also we can look and just say, that is well below what this person, this 25-year-old fellow or woman should look like. So let's just track them to see how they change over time. And we have seen people come right back, especially younger people. The CFL players, they are where they are because the last time, the average number of years between when we tested them and their last concussion was 29 years. And they still showed differences that were very different from never concussed age-matched controls.
Okay, wow. So you did touch on a bit on neuro rehabilitation. So how does neurocognitive health assessments inform rehabilitation for those with brain injury?
I think we've talked a lot to clinicians, and one of the things that they struggle with is that they oftentimes feel that even with the assessment tests, which are, as they're the ones that are always described as subjective, when they're then doing their treatment, they hope they're targeting the right area. It might take them some time to find that wasn't the right area, and they move to another domain, another cognitive domain. I think the big advantage that they have said that we provide is we give a full range evaluation. We don't look at one thing, we look at a range of things. And we can then say, this part of this person's functional profile is actually okay. There is a problem with this other area. There is a problem, for example, in memory, but they can concentrate, they can pay attention to things, but they do have a memory problem. And there are different types of memory. Everyone knows about short-term and long-term, and also there's a type of memory called working memory. And we can look at all of those things, and then we get, again, objective evidence, both in terms of the strength of the brain response, but also its timing. Like the man I mentioned, Dr. Gillette's patient, he showed the responses, but they were very, very late. So he was not okay, but he was not vegetative. So I think with all of these cases, it's we can help target the rehab. We can say, look at this area. And we have had very positive feedback from people saying, that is really what's happened. And the patients themselves, especially concussion patients, they often have a lot of insight. And they get some training, some intervention with particular areas, and they can really see the improvement. So I think that's where we contribute.
Well, it sounds like this objective health assessment really leads to a more individualized approach to treatment and recovery. And that's what every individual strives for in their recovery from brain injury.
You're right.
So I do want to let you get back to all the important work you're doing. So I do thank you so much for being with me today. This has been fascinating and eye-opening. And I do also want to thank the VoxNeuro team for all the hard work that they're doing and for their support of Brain Injury Canada. And it has been an absolute pleasure speaking with you today. Thank you so much, Dr. Connolly.
Thank you very much. It was a pleasure meeting with you.